or good afternoon rather. Sorry, we're a few minutes late. We are going to start our 340B compliance for the FQHC, presented by Keith Hanchey, who's Managing Director of Lacadian Healthcare Services. Keith, I'm now going to turn the presentation over to you.
Thank you very much, Christine. Good afternoon, everyone. I am a Louisiana native who, as many of you might remember, when Edwin Edwards was governor, he described the loss of a lot of folks as economic refugees, and I'm one of those who moved to Texas back in the 70s. But I am originally from a little small community in Louisiana called Kinder, which is near Lake Charles, and a little farming community that has become infamous as a result of the Cochata Indian tribe casino. But anyway, it's always good to connect with folks from Louisiana because I still believe that that's home. I am going to talk to you a little bit about 340B compliance, and I'd like to give you a little bit of my background to at least give you some insight as to why I come at compliance a little bit differently than maybe some do. I am a pharmacist by training. I went to pharmacy school in Monroe, and the name continues to change, but it's now University of Louisiana Monroe. I am master's trained, residency trained. I have practiced in retail settings and hospital settings. I've owned a hospital pharmacy management business, home infusion therapy business, DME. I have also sold that business and owned a hospital management company with two other friends and colleagues. And after selling that business, I went to work for Arthur Andersen, which was kind of short-lived, and then ended up as a partner at Ernst & Young. Ernst & Young has a mandatory requirement of retirement at age 60, which I did, and went to work for another firm called Navigant Consulting. In both Ernst & Young and in Navigant, I was responsible for all pharmacy services, which related to payers, providers, as well as I led a 340B team. We developed 340B as a service line at Ernst & Young about 17 years ago. And at the time, I was responsible for all of the hospital or provider services that integrated with a very large practice within Ernst & Young that did disproportionate share contracting and numbers for hospitals and other covered entities that dealt with DISH. As a result, we had an adjunctive service to work with DISH hospitals. What we found in working with the DISH hospitals, and we've implemented collectively at Ernst & Young and at Navigant over 350, almost 400 hospitals into 340B. Many of those hospitals had hemophilia treatment centers, had Ryan White grants, had strategies that utilized community health centers as well as FQHCs and FQHC lookalikes. So over the years, I have come to understand the issues around 340B and how it has grown into a fairly large business. I think that one of the things that I would like to impart, if there's any one thing, is that the compliance of 340B is a need primarily because of the government oversight that HRSA is in fact putting into place. We also are seeing a very large increase in a 340B spend which has gone from less than 0.01% to 2.5% of the total pharmaceutical spend of $350 billion this year, and it will go up as specialty totally increases. Audits should be expected. You should expect them not only from the OIG but from manufacturers. So as you look at all of those things, I suggest to you that 340B compliance and audits are not bad things. They're just part of the deal of dealing with 340B. Compliance is important because you can face sanctions now. You can also be fined. You can lose the ability to participate in 340B. And for many of you in the FQHC space, that means you would have a loss of revenue stream. The largest problem, however, is not so much those threats of audit and those threats of loss, but it's a reputational damage that the FQHC or any covered entity really does not want to deal with. The other thing that I want to make certain that you understand, they can refer matters to the OIG or to the Department of Justice should they have findings. If the HRSA audits show criminal findings or civil findings, there are now civil penalties that are very similar to those that hospitals and CFOs usually sign these cost reports. The wording of the cost report is a warrant, where the CFO is warranting that the information provided in the cost report is in fact accurate and is in fact true. The same wording that is now signed in the annual completion of the application or the recertification on an annual basis, that same wording is the same. So the responsible officers within your covered entities share that same risk that a CFO of a hospital signing a cost report does. In the past, it had a limited liability to the institution itself, as did the liability of compliance with the FQHC was limited to the institution itself. That is no longer the case. The civil risk can go straight through to the responsible officer, where there is also personal liabilities and personal risk. So if that doesn't get your executives' attention, and know that there have to be resources and know that there has to be a focus on compliance, I'm not sure what will. So I think that the entities are responsible for ensuring really three basic things under the current regulations. And that is that eligible patients receive 340B drugs. And I want to emphasize that those of you who contract all your pharmacy services out and those that do not have your own pharmacy services, the contract pharmacies are not responsible as the responsible party, nor are the software providers. You are. The FQHC is the responsible party. You also have to guarantee that Medicaid rebate is not paid on any 340B purchased drugs, which means you have to have file copies of communication with Louisiana Medicaid. Now, I would stop and say to you, please understand that the state Medicaid program is expanding into a managed care program. There is a lot of uncertainty, and there is some debate as to whether or not the managed care Medicaid is going to want to participate with 340B or not. I have a client in Louisiana who is an FQHC, and they have received information and communication that the managed care agreements or entities are not going to participate, so they should not be billing managed care Medicaid. I strongly suggest that each of you get your own clarification, because you are responsible for that, and I think that that is something that you have to be very clear on. You have to have file copies, and just be a technocrat on that. The other thing is that all other eligibility requirements are met. Meaning that you're updating the database, that you are doing internal audits, that you're self-reporting, and things of that sort. The patient eligibility is pretty straightforward, but I want to talk a little bit about some of the things that you're going to be able to expect in the future. You have to have a relationship with the patient, which is a healthcare professional relationship where you're providing professional services. You have to maintain records of that patient, be it manual or be it electronic records. You have to provide services by a professional who is either employed or under contract with you, such as the responsibility of that care stays with the covered entity. And you have to provide services that are consistent with your grants. Those of you that have Ryan White grants, or those of you that just have the FQHC grant and still receive funding, all of those have to be very consistent. So if you're an FQHC that has Ryan White, then you can provide 340B services for those Ryan White patients. You can also provide, and you're going to see additional disease states end up with not only the antiviral type therapy for the Ryan White patients, but many are starting to see Hep C integrated into their care plans, and you can provide those drugs as well. So you should also note that currently the patient eligibility has really just three major components. One is healthcare relationship with the patient, maintain the record, and the professional is either employed or under contract. You might note there that patients who receive referral services, where they're referred out for different specialty areas, are also part of that as long as you document it. The new regs are going to be a little bit more tight on that, and they're going to have that referral physician will also have to be contracted. So where you have three entities, three requirements for eligibility, you're going to have 6 under the omnibus bill regulations as proposed. So look for that and make sure that you are going to be compliant with those things. Here's some other situations where 340B becomes confusing. Like, are you aware that having only financial responsibility for the employee's health but not meeting all the rest of it may not qualify? Written by referral providers without adequate may not qualify. Administering a drug to a patient as the only service received by that patient may not qualify. So what that means is that administering a drug, like if you are just giving a patient a flu vaccine, and that's the only service that you provide, that may not qualify as 340B eligible. So I think that where we have seen hospitals, as an example, will buy all of the flu vaccine for their employees using 340B, that may not really be an eligible use of flu vaccine. So you have to go back to these particular concepts of the relationship with the patient, record, etc. Now, in an audit, you would also look at tax ID number, you would look at provider number of the covered entity, you would also look at the whole issue of where the point of service is actually provided. We suggest strongly that an FQHC have an oversight committee of 340B. And we recommend that you have these folks involved. And if you have a 340B coordinator, great. But your CEO, CFO, Chief Compliance Officer, and I know many of your small organizations, you may not have all of those things, but you really should have some type of periodic, and I would suggest quarterly, oversight of the 340B program, where you are looking at and reviewing policies and procedures. The first thing an OIG auditor will ask for is a copy of your policies and procedures. You should develop a self-audit process, and I have given you Apexis in the slide deck. Apexis has a number of different tools that you can use, and they have a self-audit process that's clearly defined, and it's something that I think that it's very easy to follow. If you were to just read and study that, you would see really and truly the depth of an audit that you can do for yourself and then also prepare for others. You really ought to audit the software vendor very often because, the things that you want to understand about your software vendor, be it CompleteRx or if it's something that you're doing something with one of the TPAs such as MedImpact, or SunRx, somebody like that, is that the software is really something that you can become self-dependent upon. But, the other audit components that you really want to look at and be familiar with is, are you being paid correctly? Meaning that, are you collecting all of the revenue streams that are part of this? Is it compliance with 340B? Not really, but it could be. Is it compliance with your contract with those folks? Absolutely. So the audit of the contract pharmacy transactions, which are like banking transactions, you want to tie those out because it does impact your cash flow. It impacts what you're receiving and what you're paying out to the distributor to replace all of these drugs for your contract pharmacies. And it also reviews the financial performance of your contract pharmacy arrangements. A lot of folks have always thought that more is better in regard to contract pharmacies. Might be the case, but then if you look at the financial performance where you might have 1 or 2 scripts a month going through there, it may cost you more than that's worth. So those are the types of things that I would look at. And I would also make sure you review the reporting that the software vendor provide to you, which are based in compliance as well as financial performance. So the issues around software that we always say to clients is, do not become self-sufficient or self-dependent upon software, and that's your only means of compliance. Software is great, does most of the work. You have to have manual audits of that software, of those transactions, to assure yourself that you are compliant throughout the 340B program. I think that the best practices for self-audits are that you are very clear and define and clearly have a procedure that validates patient eligibility. That you review a report of the NPIs. Like if you have a physician who is contracted with you that works at different places. Let's say you have a resident that comes in, and they might work at QEP Long, or they might work at Oshner's, and they also work at one of your clinics. That NPI that is electronically processed to adjudicate claims, pharmacy claims, are in fact the same NPI. And if that's the only thing that they're picking up in your software, then you have a potential compliance issue. The billing practices of Medicaid and Medicaid managed care in the state policies, has to be in the OPA database, whether or not you're carving in or carving out. Louisiana today, you can still carve out. Policies and procedures, very, very important. There are a lot of generic policies and procedures. If you don't have policies and procedures in place, those are fairly easy to get in place. And the tools on the Apexis website, I would suggest, is really, really quite good. And then you have to ensure that all the information is current on the OPA database. A lot of folks don't look at that. I look at my clients' database every quarter because things do change, and we need to make sure that they are all updated. A big question is going to come whether or not there is a need for an outside audit. I believe that you might be required in the new proposed regulations to have an outside audit. I don't know that. I think that, obviously folks that have been in the consulting business a long time think that'd be a great thing because it means they get more money and have a larger portfolio. I'm not sure that an FQHC truly needs an outside audit, as long as on the front end you have established your program well, you've trained your internal resources well, and you have a good business sense about where everybody in your organization is well informed, how important this is, and you are doing internal audits yourself. So if the self-audit process is complete on the front end, then I really don't believe that an outside audit is warranted in all cases. I think, though, that if you're not comfortable that you've done everything in order to get your compliance and your program well established on the front end, then you might need an outside audit with a corrective action plan, just to get yourself squared away. The other issues I believe that you need to be very, very aware of, obviously, are the grants that are changing, such as Ryan White. Ryan White is putting a new requirement in, is that if you have reserves that are as a result of Ryan White, that you should not be receiving additional Ryan White funding. So, which means is that if you haven't spent all of the money that you make off your Ryan White program, 340B program, then they're going to ask that you forego receiving any additional Ryan White funds. So I think those requirements constantly are changing. Those of you who have grants of all types are better equipped than I to understand that, but I would also say that this is something you have to be very much aware of as part of your 340B program and 340B compliance. So if you're audited by the OIG, what can you expect? First, you can expect a letter that comes in the mail that says we'd like to schedule an audit, and they will give you a data request. It will start with your policies and procedures. They will want to know the name of your software, and they will want to know if you have a TPA relationship in place, and they will want to know how many contract pharmacies and name those that you have under contract. They will obviously check that against the database, and they will before they come in, they will have reviewed the database and will have reviewed your policies and procedures. They will request a meeting room or an office be made available to them for at least 3 days. And then they show up, and the first thing they look at are policies and procedures, and they'll go through that with you and your staff. They will look for evidence of board approval. They will then interview your staff, and they will say, well, show me how you do this. And as you go through either an audit or look at the prescriptions and test whether or not the prescriptions are proximal to the electronic medical record, if your procedures do not align with your day-to-day practice, you will be cited for noncompliance. So what we always suggest is that you get very proactive in regard to these types of audits, in that you set those up, but you control their activities. And you answer what they ask and don't give them more information than what they ask. What you will find in the auditor is that many of them will know less than you do about 340B, and especially about the grants in which you administer. So we suggest that to our clients, and as part of our service, we suggest that notify us that you're being audited. We'll be there on site, and we will work with you and the auditor to move this thing ahead, and hopefully they won't be there 3 days. You know, FQHCs normally, unless you're a very large operation, usually take less than a day. What the results of those audits are, you will either pass or have what's called a corrective action plan, or CAP. The worst performance with no controls and diversion, usually end up being removed from the program, and they will give you a corrective action plan, which would include the repayment of overpurchases or diverted drugs quantities to the manufacturers. There is an appeal process. We find the appeal process to be limited in regard to the ability to really reverse something, though we've been successful in some of those where it was warranted. But normally the correction action plans are a result of really not having policies and procedures in place, not having oversight in place, not doing the self-audits, and not really being aligned with your actual practices to the 340B policies and procedures. So there are a few other nuances that I suggest that you kind of take a look at, like how are you using penny purchases, and do you know what a penny purchase is? There's a provision within the federal law that says that any pharmaceutical manufacturer that contracts with the Department of Defense, VA, Medicaid, or any other federal program must comply with all provisions of their contracts. If for some reason they do not comply, and it is shown that they are in non-compliance, they have to sell their drugs to the 340B program for a penny for 1 year. So what that means is that if you have, if you look at the 22,000 plus SKUs that are covered by 340B, if you have, let's say, a manufacturer that has a particular branded drug that is part of the penny purchases, then you would want to, if the clinical outcomes are going to be the same or better, you would want your physicians, obviously, to prescribe those penny purchases. The reason being, it increase your margin. a penny versus whatever the cost of the drug is increases your margin dramatically. The other thing that I suggest that you become very much aware of is the revenue stream correct? And then how do you know? And you know based on what usual and customary is, but you also know if you're using a software package such as CaptureRx or SunRx or one of those, they can tell you what the expected payment should be. So that payment that you should be collecting is something that should be audited. And then do you purchase or replace the contract pharmacies or the price is correct? I've been in the pharmacy business now since 1970, and I can tell you that we audit wholesale purchases and invoices, and we normally find anywhere between 0.5 to 1.5% in error rates, and which means that in most cases we find overpayment to the wholesalers. So if you audit those things, there's probably a business case that shows you will save additional monies. And then the net receipts from the contract pharmacy, obviously, you can test those things. So what I've described to you is an audit process that is not only auditing 340B compliance, regulatory compliance, but also 340B financial compliance, which is as important to an FQHC because it does fund your mission. I guess, Christine, we have about 25 minutes and be happy to answer questions. I know that was high level and pretty fast to go through a lot of those things, but those, we can boil it down to just those entities or those criteria of compliance. There are a lot of nuances around it, but those are the basic compliance issues that you have to deal with. So I'll be glad to answer any questions or have any communications with you that you like.
Okay, thank you, Keith. I have a couple of questions up front that have been submitted, and then I'd like to invite everyone who's participating on the call to go ahead and type your questions into the question box of the webinar, and we'll be happy to address those. The first question is, you had mentioned a 340B policy and procedure toolkit that was possibly available. Can you provide either a website or a resource for a template and or toolkit?
Yeah, the last slide, which is up now, has apexis.com. And it also has 340B University, which you can attend online, as well as their covered entity tools. And in those tools, I've listed the independent audit RFP checklist, a compliance, 340B compliance for the C-suite, getting started with a compliance guide, 340B and Medicaid, and self-audit checklist. All of those are tools that are at apexis.com. There's a woman at Apexis whose name is Catherine Richardson. And Catherine and I wrote a lot of the policies and procedures for covered entities that are out there. She continues to enhance them and continues to make it a whole lot better. She is a pharmacist by training, lives in Tennessee, but is remote with Apexis, who is located here in the Dallas-Fort Worth area.
Okay, thank you. The next question is, to your knowledge, how often should a health center expect an audit of their 340B program, and what are some of the common corrective actions that are required for noncompliance?
Sure. Well, I think that an FQHC should be prepared for an annual audit, though I think the probability of an annual audit is less than 50%. I think the common corrective action plans are not finding policies and procedures that are updated and approved by the board. I think that when they come in and audit a contract pharmacy, what they will do is pull 30 records, and they will ask, those of you that have electronic medical records, they will ask for 30 patients to be brought up. They will look at that, and then they will see, okay, where in your contract pharmacy records show that it was filled. And then they will test whether or not it's proximal. And what that means is that proximal to the visit means that a prescription is written based on the codes or the coding of that particular visit. Let's say I come in and I am diagnosed with diabetes and I have multiple comorbidities. The prescriptions might have a number of different things that show related to diabetes and comorbidities, and that would be proximal to the visit. If I had some performance drug, erectile dysfunction performance, that would not be proximal. That would not be 340B eligible. So those are the types of things that they will test, and those are the types of things that you will see corrective action plans on.
Okay, thank you. The next question is, can you apply a sliding fee scale to 340B prescriptions?
Repeat that, please.
Can you apply a sliding fee scale to 340B prescriptions? Are you familiar with the sliding fee scale?
I'm not, no.
Okay. Then we will research that particular question and get back to the asker. The next question is, good afternoon. I'm a little confused about what you mentioned at the beginning regarding what we need to ask the MCOs. Perhaps I misunderstood, but if a client has Medicaid, we do not consider them for 340B.
You can't bill 340B to Medicaid or Medicaid managed care if you are carving them out. If they are not carved out, like it's my understanding, and I want to make certain that you check this, but it's my understanding is that some of the managed care organizations in Louisiana do not want to participate with 340B programs because they want to receive all of the rebates, and that they think that rebate dollar amount to their organization is greater than the discounts that they would receive under the cost of drug therapy that are 340B eligible. The state, if you carve in the state Medicaid, not managed care, but the state Medicaid, you get a prescription dispensing fee that is higher than the normal dispensing fee. But I think it is one of those things that is shared with that it shows that the state Medicaid program then is not going to get rebates for those types of 340B prescriptions. Now, what you have to do when you are dealing with state Medicaid is in the application process, you have to state, are you going to carve in, which means you're going to pass through the 340B savings to the Medicaid program, and if that's the case, they cannot use the rebates, manufacturer rebates, cannot receive those. Or you carve them out, which means that you bill at usual and customary, but you cannot use 340B at that cost. At that point, you would use WAC. Does that make sense?
Thank you.
Okay.
If there are any other questions at this time, please go ahead and type them into the question box. And while we're waiting to see if there are any additional questions, I would just like to note first and foremost, thank you, Keith, for your presentation today. If anybody would like to get in touch directly with Keith with any follow-up questions, please send me an email, and we'll make sure that we get you your question in front of Keith. Also, we do have our next compliance session will be on July 27th, beginning at noon. The topic of that session will be around human resources compliance, focusing on exclusion lists, licensing and certification, and education levels. And there will be an opportunity to pre-register for that session being sent out via email in the near future. The next question that has come in is, have you seen a case where either the CEO and CFO have received a civil penalty?
Yes, I have. There was a covered entity in the Northeast, which it was a client of mine. That we were involved in the case. They were not, the covered entity was not a client, but the state Medicaid program as well as the Attorney General sued these folks, and they did have civil and both civil and criminal charges brought against them. I'm underprivileged on that particular client, so I cannot give you more detail than that.
Of course, I'm sure they appreciate that. But it is good information to have for those health centers who may be concerned over that, and as far as understanding the great level of responsibility that each member of that team holds to their 340B compliance.
Christine, I would also mention to all the participants, which I was told many of you are compliance officers of your, what I also find and have found over the years of dealing with 340B is that the more compliant that a covered entity is, the greater their savings or the greater their revenue stream in the case of FQHCs. I have found that a little bit of investment of time, resources, et cetera, into the compliance on it has been a tremendous financial return. And I can give you examples for the last 17 years that I found that. Most of that was in hospitals, of course, but the FQHC and community health centers, and Ryan White especially, the more compliant you are, the more revenue stream you will see, and further, the less risk that you will have for the program, and all of that's good.
Great. Thank you so much again, Keith. And if there are no additional parting remarks that you'd like to make to the group, we have no further questions, so we will end the broadcast.
The last thing I would say, Christine, is that I'm getting toward the end of my career, which has been fun, and I've enjoyed every bit of it. I am giving back a great deal, do a lot of volunteer work these days, and should any of you in Louisiana, especially because you are my home state, have issues or any type of question around 340B, you can call me, you can email me, and there's absolutely happy to help you. There's no charge for that. Obviously, if I'm engaged to do something more than a phone consult, then I do charge for that. But if you just have questions and unsure or want to be pointed in the direction of where you can find good legal counsel or be introduced to the people at Apexis, Catherine Richardson is a great resource. The people at It's called 340B Health now. It used to be SNAFA. You know, Ted Slavsky and all of those folks up there. I know them all and be more than happy to facilitate calls or assist you in any way so that you're comfortable with 340B and it becomes and continues to be, you know, a revenue source that you can continue to receive and, you know, expand your mission, take care of your patients and your business. So I'm happy to do that.
Thank you. That's very generous, Keith. One last question has come in, and this participant would like to know if you can recommend an external auditor.
Besides myself, yes.
I guess yourself would be the best plug if you do that as well.
Yeah, we do that as well. But yes, I can recommend. You know, there's a group of folks who worked with me at Ernst & Young and at Navigant called Alignia. If that person who asked the question will just email me at keith@legadiancompanies.com, I can give you their contact information as well.
Great. All right, there are no further questions at this time coming in. So once again, Keith, thank you very much for your time and your presentation today. And if there are any follow-up questions that the health centers think of after the session, please feel free to either contact Keith directly, or you can send your questions to me at cforstner@lpca.net. As I'm sure if you have a question regarding 340B and audits and everything, there's likely to be a good number of your colleagues and other FQHCs who may have the same questions, and we'd like to be able to share those with everyone. So thanks again, everybody. You have a great afternoon, and we will see you hopefully again next month at our next session. Bye now.